Well, welcome everybody to the Executive MHA interview series. We're here tonight with our students of the first cohort. This is their first week, and welcome all of you. I'm very pleased tonight here to have Dr. Peter Person with us. Peter is the CEO of Essentia Health. Essentia Health is a multi-state integrated health system headquartered out of Duluth, Minnesota, with assets in Minnesota, Wisconsin, Michigan, North Dakota, and Montana. Peter is the CEO of Essentia Health, Mayo-trained physician, and heads the organization. The focus tonight is really the health system design as a platform for innovation. So the focus tonight is whether integrated healthcare really provides an opportunity for innovation that other structures do not. A little bit of history on Peter, which I think it's important for the group and really sets a context for what we're going to talk about tonight, is that in 1995, he became the CEO of the Duluth Clinic. He was the 100th physician. I think I have this right. Duluth Clinic started in the early 1900s. Correct. Largely, I think it was the nidus of it was Mayo-trained physicians. So Peter became president of that, was a practicing internist at the time and critical care physician and intensivist. Became the president in 1995. 1997, they merged the Duluth Clinic with St. Mary's Hospital to create an integrated health system, St. Mary's Duluth Clinic, which was really very innovative, certainly for rural health care at the time. 2002, Essentia Health was formed. Essentia Health was initially formed with the integration of the Benedictine health system, a Catholic health system, with St. Mary's Duluth Clinic. Subsequent to that, in 2006, there was a merger of Essentia Health with Dakota Clinic, Innovis, and they became part of Essentia Health. The health system moved west from there, developed some joint ventures and some relationships with the Great Falls Clinic, Great Falls, Montana, moved west from there and developed relationships and integrated structures in Idaho as well. So Peter came here tonight to really talk about health system design and structure as a platform for innovation. The course that we've been focusing on this week is innovation in healthcare. One of the questions on the table that we've been addressing and we'll address tonight is whether structure is really a platform for innovation. So the focus here tonight is integrated health systems. We have a series of questions that really are going to guide us along, but we're going to be relatively informal with this. At the end of the questions, I will open it up to the floor and for our students to please ask questions relative to what we're talking about this evening, and Peter and I will do our best to answer those. So Peter, thank you for taking your time here tonight.
Thanks,
and
Dan.
I've had the pleasure of working with Peter for a long time and call Peter a friend as well. And so we've been through some things together, and it was very kind of him to spend his evening with us. So let me get this rolling. And I do have some structured questions, but feel free to wander off the questions. And if you don't think I asked a good one, ask another one and answer that.
Thanks, Dan. I'll wander.
It happens. First, you lead what can reasonably be described as a fully integrated health system. That term is thrown around a lot in the marketplace. We really need to start with your definition of an integrated health system. And what do you think the distinguishing characteristics are of an integrated system? Because, as I said, we hear the term thrown out a lot. And I haven't really heard a good, solid definition. So if you have one, let's hear it. But we'd really like to hear some distinguishing characteristics.
Well, thanks, Dan, and thank you all for allowing me to participate in your course. I think that question is, in many respects, foundational to how we look at healthcare at Essentia Health. In our leadership group, we often describe organizations as being large I integrated versus small I integrated. As you said and suggested, a lot of organizations now call themselves integrated. As you start asking those members of those organizations what they really mean, you really come to a better understanding of their definition of integration, and I think it gets to the heart of your question, which is what are those principles we consider to make up a fully integrated organization. In our organization, at Essentia Health, our physicians are employees of the organization, and as are all the employees. So we consider as physicians ourselves employees, but we like to consider ourselves partners. Partners in the agenda, the strategy, the overall direction that the organization needs to take. I think some of the key principles have to do with as follows. For us, we define a fully integrated system as a system in which the physicians play an integral part in the success and the overall operations and management of the organization at all levels. Many organizations consider themselves integrated if they have a physician group practice, but often those group practices sit on the side or in a silo. They're run in a traditional group practice mentality, but they have a president or a chief medical officer or a VPMA, Vice President of Medical Affairs, who relates at a senior leadership table with the traditional leaders of a hospital or a hospital system. But there's not real integration at the lower levels, at the department levels or at the section levels, where you have physicians working directly with administrators or staff in the development of strategy or strategy to support the organizational strategy. You have physicians who are capable of talking about profit and loss statements. You have physicians who are engaged in management as well as leadership of the organization. So for us, an integrated organization is where you have physicians almost always working as employees within an organization, but they're actively involved in the day-to-day management and in the day-to-day responsibility for decision-making, including the financial aspects of the organization.
You know, you mentioned here tonight, and I've heard you mention a number of times, this distinguishing characteristic of a physician as an employee versus a partner. And I know you favor the partner
Sure.
side of this. Talk a little bit about, you know, you obviously have been there a long time. When you walk the halls every day and you're seeing patients and you're part of administration or you're part of management, what's the difference between feeling like a partner and feeling like an employee?
Well, I like to say, and I've said it often, that physicians make great partners but lousy employees. I think that has a lot to do with the way we're trained and the background that all of us have as physicians in terms of this great sense of personal responsibility. For those of you in the audience who have had the luck of going to medical school and spending time in your training program, I think you know what I mean. In the medical field, as you move through the basic sciences, and now even at the beginning, they really imprint on your thinking and the way you act and on your behavior the ultimate accountability that you as an individual have in that patient's ultimate care and the decision making and the outcome of whatever service you're providing. And so there's a lot of emphasis placed on personal responsibility. In my business school background or in my business school training and also just being part of hospital structures, there's much more, and it's probably not overt, but there's a clear sense of hierarchy or shared responsibility or a hierarchy in terms of decision making. And so what you get into as a physician is the conflict between a hierarchy and responsibility. And I think in an organization, one of the ways that you can deal with that is not refer necessarily to the physicians as employees, which implies structure and hierarchy, but you refer to each other or you refer to the physicians as your partners. And that's how we have characterized our relationship with the organization. So I feel I have an ownership in the overall outcome of how the organization does financially. I feel like I have a personal responsibility as a partner in this organization for employee satisfaction, for how the employees feel about the work, and certainly all of us as partners have an ultimate sense of responsibility to the community. So it's maybe an art form where you talk about being a partner, but I think it implies a different kind of relationship. When I deal with a physician colleague, I usually approach those discussions as an equal or a partner, or as someone who collectively we're focusing on patients. When I meet with an administrator, it's often financial or contractual or a management relationship. So I think the partnership discussion or the partnership relationship goes a long way to meet some of those needs that we as physicians have.
You know, when you look around the country, there's a number of folks attempting integration in a number of ways, and I heard somebody recently say, well, you know, if you've seen one integrated model, you've seen one integrated model, and I still hear executives, health system executives saying, you know, you really don't need to integrate physicians as employees. There's a whole bunch of other models for that. You know, and I've heard you, and I'm certainly a believer that these sort of 101 deals get a little complex to manage. And when the physicians are really part of the organization, they're employees, they're partners, it's just easier to get things done. It's more facile. You can move the organization. You can make decisions quicker. You're strategically more nimble. Do you believe that? Or can you integrate doctors in 1,000 different ways?
You can integrate them in 1,000 different ways, and I think that I've seen probably 50 of those different ways being attempted as I've gone out and talked across the country. I think ultimately the advantage of this partnership model, or for what we are using as this platform of integrated care, is that we're all under the same mission. We all have the same vision statement. We all operating under the same principles. We all operate under the same P&L. And one of the premises, I think, of the discussion tonight is the integration platform is a platform for innovation. As I discussed a little bit before we started, in 1995 and from 1981 to 1995, when I was part of the Duluth Clinic as a practicing physician, we were not integrated. And I saw up close and personal the shortcomings of being even a large multi-specialty group practice, the largest multi-specialty group practice north of the Twin Cities, and the shortcomings that had in terms of how we related to the hospital and everything that happened within the hospital. Most conversations that we had, whether it was in how we were going to structure something in the intensive care or how we're going to do a particular clinical program, every conversation seemed to have a chief operating officer from the hospital. They often brought their legal counsel. We often brought our legal counsel because they brought their legal counsel. We had our chief operating officer, our chief medical officer, their VPMA, and all of this structure and all of this kind of administrative overhead to deal with something that was pretty straightforward. It was complex. It was rarely a win-win. It was more often than not, it was kind of a tie because always you were dealing with the financials. And at the end of the day, the best you got was, well, let's do this for a year and then let's renegotiate based on what we learned this year because someone may be winning more than the other. That's not a good way to deliver care. But when we moved to this new model, when we became a single system, all of us on the same page, all of that went away. We didn't have to have our lawyers in the room and lawyer up to have a meeting. We could say, what is it that we want to accomplish? Where is the best place to do physical therapy? How do we provide therapy services across the inpatient and the outpatient? How do we start educating our orthopedic patients who are going to have a total hip in the clinic? how do we take the social worker from the hospital and move them into the clinic setting so we can start getting discharge planning done on the outpatient as they're coming in. Those were the things that were so refreshing to us. I think that was the beginning of the understanding of the innovation that we could accomplish, because all of that other stuff just got in the way of what I wanted to do as a physician and what I think my colleagues wanted to do. And you look across the table at the hospital folks, and that's what they wanted too. But it was all driven prior to the integrated platform by legal requirements. We didn't have HIPAA then, but certainly HIPAA would be all over that now, and all the other regulatory requirements.
I'm going to wander a little bit off the script for a moment, because I've heard you tell a terrific story, and I think it'd be useful for the students. The Duluth Clinic was really one of the few organizations that, in the history of integration, actually initiated the integration talks. It really was the hospital that held back, and you tell the story, and I hope you're willing to tell it.
How honest do you want me to be?
I want you to tell the parking ramp story, if you would, please. That what really triggered the clinic and the physicians leading the charge for integration. Tell the parking ramp story, if you will.
Yeah, this is a great moment in my history. But one of the things that I've talked about and I've shared with people, shared with physicians, because I really think that until you have responsibility for a balance sheet, an income statement, or a budget, and employees, we really kind of dance around the edges in terms of leadership and leadership development, and I think we fast-track docs through that, and we take them away from that responsibility. Well, in 1995, I was elected president of the clinic, and that was 1997 was the Balanced Budget Act was just coming into play, and we had grown at that point to maybe 250 physicians. We had cardiac surgery and neurosurgery. We had everything that you wanted except for money. We had about 50 cents in terms of our retained earnings. We had no money, basically. We really generated a lot of income. We generated a lot of margin, but it all went to cover all the services that we were developing in that. And so, shortly after I became president, we didn't have enough money to cover payroll. And I had to go across the street and knock on the door of Sister Kathleen, who was the CEO of St. Mary's, and negotiate with her, her buying our half, or St. Mary's buying our half of the parking ramp so I could make payroll. It was a great initiation into what it meant to be a leader. I really learned a lot at that point in time, but it really at the same time set off in my mind a whole set of questions like, what are we doing? This doesn't make a lot of sense. As I mentioned before, it came from Mayo. When I was down in Rochester, the Mayo Clinic had merged with St. Mary's and then Methodist Hospital. And that really seemed to be the right way to do things. I mean, we were watching the activity that was happening in the CCUs and the surgery suites, and we would see every year their published income statement information, and we would look at ours and we'd say, what's wrong with this picture? And yet they would come to us every time they thought it would be important to expand our services and so on. And so that whole, I think, challenge of going and knocking on someone's door saying, I need to sell our parking ramp to make payroll, really played out in my mind a much bigger picture, and I think an agenda that when we sat down and talked with St. Mary's about it, they said, absolutely, because we were seen as vulnerable, we were seen as potentially joining FICOR or Mayo. We were 95% of St. Mary's admissions at that point in time. They didn't want their entire medical staff joining some other organization or going in some other direction. So, but anyway, that's the parking lot story, and I'm not sure I should be proud of that, Dan, or.
Well,
but sometimes, you know, crisis is the mother of
invention,
of invention
or innovation.
Innovation. That's right. That's right.
You know, the students and the faculty have been learning together about healthcare reform, and what we've pretty much figured out so far is nobody's got a very clear picture of it. Without talking about specifics of healthcare reform and how it might turn out or not turn out, if you think about a reforming healthcare economy or a reforming environment, I gotta believe that you think the fully integrated model is best prepared for anything that comes. And I know I'm putting words in your mouth, but I'd like your opinion on how the fully integrated model is going to stand the tests of any kind of reform that may come along, presuming you believe that.
Well, I do believe that, and I think, at least from our perspective, I think that the ultimate conclusion of this, at least in the next 5 to 10 years, before we get into something more innovative out of the federal government, is going to be more and more cost-cutting. I think that they're just going to have to drop the Medicare rates. I think they're going to move in some areas to bundled payment, where they'll pay for X number of dollars, like a DRG, but it's going to cross the inpatient, outpatient lines, and they'll be covering a hip replacement or a cardiac procedure or something like that. I think the integrated platform with employed physicians who are active in management, and when you think about it, at the end of the day, like it or not, the doc is the guy, the man or the woman, or the PA now, but under physician direction ultimately, is the person who is going to be writing the order, is going to be ordering the supply, is going to be making the decisions about the care that needs to be delivered. So I think if we're in a cost-cutting mode and at the same time trying to improve quality, which gets into the whole value equation, you're going to have physicians fully engaged in that. You're going to have a model or a platform that is as efficient and as quick and I think as effective as you possibly can get. There's not going to be a lot of time to lawyer up and have joint venture or joint operating agreement meetings from one organization to another. And I know some organizations that have just got multiple deals with group practices, and they say, well, we're an integrated organization. But they're going to be, I think, over their head quite quickly as they try to work their way through that. So I think that that's the future. I think we're going to have to be as reactive as possible. The flip side of that is this environment has caused the insurance plans and to some respect the federal government to start looking at innovative programs. And Medicare is doing a number of demonstration projects, accountable care organizations, and so on and so forth. We find the commercial payers are very open now to sitting down and talk about risk sharing. They want to make sure that there's value in that for them, and we want to make sure there's value in that for us. But to get to that next level of looking at capitation or risk sharing or whatever you want to call it, you really have to have a sophisticated structure. You have to have a sophisticated medical group. You have to have sophisticated support. You have to have integrated hospital and physicians working together efficiently and effectively. That's where I think that this brings a lot of benefit. At our senior leadership table, we don't spend a second's worth of time talking about inter-organizational politics or which group is upset about that group, about the orthopedics, or upset with cardiology, upset with neurology or neurosurgery. That just doesn't enter into our conversations. But I think in a different format or a different form of integration, that's a very real possibility, and that probably happens a lot.
We have a very sophisticated group of students here, and one of the points I made and I will make again is that, and maybe you can help them appreciate that because I'm not sure I did a great job, but I said in the integrated model relative to health care payment reform, and to be honest, I don't see much about health care reform in the legislative proposals. I see it mostly as health payment reform. But that aside, I have said it's really, for the integrated model, it's not that important how revenue flows. It's only important that revenue flows, meaning that the integrated model allows you a mechanism to equitably distribute money, whereas in some of these accountable health organizations, some of these deal the week structures, the problem they're going to have is figuring out if somebody puts a dollar in the middle of the table, how they're going to divide it.
Right.
So is it so easy in the integrated model that, you know, internally it really doesn't matter how the money flows, it only matters that the money gets to the organization?
Yeah.
Yeah.
Yeah, Dan.
Because you've got a compensation system, you've got...
I don't know if Dan told you, but Dan, for 2, if not 3 years, was our chief operating officer up at Essentia. So Dan is well aware of a lot of these concepts he's talking about, and he and I certainly shared in that same vision. But yeah, that's exactly right. The dollar flows in, and we now have the ability to define how that goes and where that goes, and how to structure ourselves to be more efficient in the terms of how we deliver that particular kind of care. I'd like to say, I'd like to add at least one thing. One of the challenges we have is that we're in rural Minnesota, rural North Dakota, rural Montana, rural Idaho. I mean, we are really, really rural. I can tell you that in a town of 4,000 people, with a separate physician group practice and a separate hospital, there is no other way than to be fully integrated that you can make sense out of that. And for many of those small communities to recruit physicians to a town of 4,000 people with 4 or 5 family practitioners with no support, after all of them have been trained now in sophisticated medical centers across the country, it's going to be increasingly more difficult for these rural communities to both attract physicians, keep their hospital functional and alive, and have quality care delivered. And so our approach to not only the way we build and deliver care in Duluth is the integrated model, but everywhere we've gone, we replicate that. So when we are in Brainerd, when we started with the BHS, which Barry Holm was part of, the physician group was independent. And we said right away, well, that isn't going to work. Our model is an integrated platform, and so we've gone about and accomplished that. And then we have the ability to work with smaller communities around Brainerd, and they become part of our system. We can provide outreach, or we can provide through telecommunications or PACS system or whatever, a lot of support to the physicians who are practicing out there. And I think it ultimately will deliver better care for all of them. So it's a platform not only for innovation, but you can start moving innovation and better care out into these rural communities that without us are really, or without an integrated platform, are really going to be struggling in the future.
Several of the students today who are from integrated organizations talked about something you've talked about a number of times, and that is sometimes the innovation on the clinical side, and let's switch gears a little bit and talk about the clinical side of things in patient care. Sometimes the platform has allowed for clinical innovations that have actually been ahead of the reimbursement. An example would be heart failure.
Correct.
Where organizations represented here and Essentia, especially St. Mary's Duluth Clinic and other components, have really been ahead of the reimbursement curve because it was the right thing to do for patients. In other words, you were out there doing things for heart failure management that you didn't get reimbursed for, yet you did them. Right. Did the innovative model allow you to get ahead of the reimbursement but yet make it affordable? Is there anything that allows you to be more innovative clinically even before the reimbursement catches up?
I think there are a couple ways of looking at that. One of the ways, when this came back to me and I asked myself and our group, well, are we doing the right thing? I mean, we knew we were doing the right thing, but how long could we continue to do the right thing? we came up with a couple of answers. One, for us now to expand our hospital, St. Mary's in Duluth or any of our hospitals across the system, what is it, $1 million a bed to put in
At least.
a new bed, $1.2 million. So let's say we've got an aging population, an aging community, and we've got all these people with heart failure that we choose not to take care of on an outpatient basis with the technology that we had because, quote unquote, we lost money. Well, if you step back and say, well, how much is it going to cost to build another 40 beds on St. Mary's to support all these people who are coming in with congestive failure now that we have to take care of? And oh, by the way, we usually lose money on that. It really became clear to me that it was the right thing to do, and in the long run, it got us to the point where we didn't have to build new hospital beds, which are very, very expensive, because we were doing the right thing. Patients loved it. Our finance person didn't like it until we reminded him that the cost of expanding St. Mary's was 30, 40, 50 million. Then all of a sudden Bert said, this is a great idea. Hell, we got to do more of this.
Yes, take care of patients better. This is a good idea.
Right.
Yeah.
And the other thing that I was telling Dan about before we came over here tonight was we're finding that our hospital admissions are actually down from last year, probably like for everybody in this room, but also we're finding that this year, interestingly enough, we're more profitable than ever. And what's happening is our surgical cases are, and this unfortunately is a testament to the way we get paid, but our surgical cases haven't really fallen off. We're still doing as many gallbladders and bypasses and hip replacements and hip fracture repairs we did before. And Medicare still pays enough for that to be a profitable business line. But our medical patients are where we're really down. And for every medical patient that came in that's Medicare or county or Medicaid payment, we lose money. And so we're really doing a good job in managing care on the outpatient side, keeping those folks out of the hospital. Now, do we get paid to do that? No. Is there a care management fee? No. But we make up a lot of revenue, or we reduce our expenses in that these people aren't in the hospital. So in the end, the patient's happy because they don't have to go in the hospital. I think we're happier because we don't have to build to deal with this increasing demand. And at the end of the day, we're reducing our costs in terms of our expenses because the reimbursement system on these folks just isn't the same as on our surgical folks. Now, that's a whole different debate about whether that's fair or not, but that's what we're seeing happening.
Several years ago, you really took a risk and you stepped out, and I'm going to wander a little bit off the scale.
And hired you.
Yeah. And then you rethought that idea,
right. And now Dan's down here.
And then we moved on, and now he found another job, thank God. And yeah. Thank you.
You're right.
Thank you. You stepped out and you took a risk and you said, we're going to put in an electronic health record. It's going to go through the whole organization. We're not going to debate it. That's what we're going to do. You decided to go with Epics. It was a good idea, but talk a little bit about why it's become a good idea. Is it a good strategic tool, a good clinical tool, all of that? And I presume you'd do it again if you had the decision to make.
Yeah, it was one of those decisions that we were making when I was down at St. Thomas and I was with Tom Gilliam, and I remember going home and saying to my wife, there are probably three things that are going to end my career. One of them is 2 or 3 bad years. I said, that's a given. I forgot what the second one was, but the third one was poor installation of an electronic medical record. Each one of them was going to cause me to lose confidence, one with the board and the other with the medical staff. And I think that the decision process that we went through was a good one, and I think ultimately to move to electronic medical record was, across our system, was obviously the right thing. You know, these systems, EMRs, have different bells and whistles and different flavors. Most of the folks in this room are familiar with Epic. We've chosen that. But interestingly, in Fargo, they're using Cerner. And in Brainerd, they're using Cerner as well. We have one system in a smaller hospital. It's called Dairyland, which always was intriguing to me. And I think we got some on Quicken, and we got some on, you know, the
Pegboards.
and
Pegboards are us.
white sheets of paper. But what we found is that in the decision we are making now is we need to move to a common medical platform, a common EMR across the whole system. We feel that we need to have, through an electronic data warehouse, we can tap into all the information, we can do a better job of managing patients, we can better define value, we can provide support, whether it's clinical or managerial support across the whole system through that single platform. Our docs who go out on outreach, and primarily it's been from Duluth to International Falls or Ely or Hayward or Ashland or over to Deer River. Obviously they can use the same common medical record, all the information is available, PACS system and so on, and a lot of these are subspecialists who are going out, so that's been very helpful for them. We see now the ability to be our own Nighthawk radiology. There's no reason why our Idaho sites need to be contracting with Nighthawk when we can provide those at-night radiology services. They have a robot, and we're looking into remote ICU monitoring, remote ER assist with a robot that moves around, and you connect a small rural community with a trauma surgeon in Duluth or Fargo, and you really can support them in a way they've never been able to have support, which also makes it easier to attract those folks when they're leaving their residency. So it's almost, well, it is a given now. Everyone has to have it. All the folks coming out of medical school and training now are all saying, well, what do you have? What's your platform? It's not even a question of paper and pencil anymore. It's what's your system and how integrated is it?
Let's switch gears a little bit to strategy, and one of the things you and I have focused on a lot over the years is the efficiency and effectiveness of the integrated model in strategy. As folks who know me know, I'm fond of saying I don't like a fair fight. So I'd like an advantage over my competitor. I'd rather compete where my competitor can't. And one of the things that at least I found useful about the integrated models is you could compete strategically where the traditional models just couldn't touch you. An example was risk, contracting for risk. One of the examples we've talked about in class and we'll continue to talk about is somebody comes and says, I'd like to pay you for performance relative to how you take care of diabetics. Well, to enter into those contracts, there's some essential elements. One, you have to know how many diabetics you have. You have to know baselines. You have to be able to change care styles. What kind of wisdom can you give the group or experience on the strategic facility of the integrated model and what that's allowed you to do from an innovation perspective for strategy?
Yeah, I think we're just entering into that whole dialogue. I'm not aware of a lot of that happening yet. I mean, we are just being approached by the commercial payers and others to sit down and have those kinds of conversations. It's the next step beyond pay for performance based on how many people got aspirin after they developed chest pain and that, which were just process indicators, and I think they knew and we knew that that was the case. I see two things happening, Dan. I see the insurance companies again responding to the health reform debate and interested in partnering with people. And I see a lot of healthcare delivery systems or hospitals quickly acquiring physicians and group practices or single practices and developing a group so that they can They can participate in what I think will be bundled payments or pay for performance, or even that next level where we're managing populations and managing their diabetes. We're fairly far along, and we're just beginning those conversations. But what's happening is that when the commercial payer comes to us and then he or she goes to our competition down the street, they always come back and say, well, you're way, way, way ahead of them because of your platform. They're an integrated system, but they just don't have that kind of internal communication, and they, our competition, will say, we're not quite ready for that. One of my frustrations with the Minnesota state healthcare reform debate is that there's only a few systems in the state who have been supportive of some of the more aggressive, possibly drastic approaches to healthcare reform in the state of Minnesota, because you have to have this integrated platform, and you in this in this group probably know who they are. But the vast majority of providers and systems in this state aren't there yet, and so they've been dragging their feet. And so the legislators have had to, they've been fairly frustrated at the fact that we haven't moved as quickly as we can. We've been pushing, and many have not been able to get there yet. So.
When you look at capital access, certainly Ascensia has gone to the marketplace recently, and if you scroll back a few years and look at some of the rating agencies, the Fitches, the Moody's, and the S&Ps, they were pretty skeptical on integrated health systems. It was, geez, I don't know, these hospitals are buying doctors and they're losing a ton of money, and this is a bad idea. They've sort of changed their pitch, and they've changed their tune, rather, in that the rating agencies are starting to say, well, wait a minute, what's your physician strategy? Are you going to be integrating physicians? Do you have an opinion on access to capital in the future, the integrated model's advantage, if any, versus the traditional private practice model and the access to capital?
Well, one of the things that I was amazed at the first couple of times I went out to New York and was involved in borrowing money was what they ended up calling the soft stuff. They always looked at the ratios. I mean, everything started and many times ended with the ratios, what were your days cash on hand and cash to debt and so on and so forth. But then they said, what are the soft strategic factors? What's your physician strategy? You're integrated. How are you integrating? Because they've dealt with the Mayos and the Clevelands and the others. They're not unsophisticated. They were very sophisticated, and they were able to look into your organization and see how you were running it. And then Barry has been out there once or twice with me. And then they would say, how long have you been at this? Because there is a maturation process that goes on. We are miles and miles and miles ahead of where we started, thankfully. And they were cognizant of that. But if they knew that this was the direction you were going and this was your model, and then you were making these suggestions or these commitments to operating performance in the future, they could bring all these factors together. Integrated model, strong market presence. You had a certain critical mass in terms of all the folks that were involved. And you've been doing this for long enough that they said, yeah, this is above and beyond, or this is an addition to the various ratios that we're looking at. This is synergistic to that, and actually you could do better than the ratios alone would suggest based on these strategic factors, how you were integrated and what your physician strategy was.
Critics of the integrated model in terms of an innovation would say, fine, you put doctors together, okay, I get that. Fine, you're doing some pretty innovative clinical stuff, I get that. But you're going to lose money. It's a bad financial deal. You and I have talked a number of times, and you have made it work. And the sort of the mantra was, when you get in an integrated model, it really is more of a formula business for financial performance. If you have more control over the moving parts, you execute on those moving parts, the ability to make money, even in a pressured environment, a Medicare environment, a Medicaid environment, is more available to you. Do you buy the fact that once you figure it out, it's easier to control your financial future in an integrated model?
Yeah, and I think that I can almost guarantee that the first 2 to 3 years will be really tough sledding. We went negative the second year as an integrated system, so this was 1999 or 2000. It took us a couple of years to dig out from under that, and we've had this steady upward improvement in our performance. Despite being in northern Minnesota providing rural health care, our margin now is the highest it's ever been in my entire professional career. And this is in Duluth, Minnesota, Hibbing, Sandstone. I mean, we're talking small rural health care, and we're doing as best as we have ever done. I couldn't have said that 5 years ago, and we continue to see improvement as we get better at what we do. We also are bringing what we call our operating system out to Brainerd and saying, you know, you can wander in the wilderness like we did for 11 years and sell your parking ramp and so on, or you can adopt this approach, which is scalable, and they've all said yes, thank you. And the same thing in Fargo and the same thing at Detroit Lakes. So it's tough at the beginning, but in the end, I think it's the best way. I think at the end of the day, the integrated platform is going to be the best at adapting, because you've got everybody on the same side, so to speak, and you are operating under a common mission and a shared vision, and you can deploy your resources as you need to. And we've had to cut and trim and so on and so forth, but we do it, I think, in a way that's really been, I think, quite sensible, and it's been, in the end, it's been pretty effective. Coming back to one of the things that you had talked about, our partnership model with our physicians now, our docs have said, we want to go at risk for the budget. We want to put 5% of our income at risk overall. We'll take a 5% cut. We'd rather take a 5% cut if you don't hit budget rather than lay off employees. We think that we shouldn't be protected. These are the people that we've spent in many cases 20 years of our lives together, and we have laid off physicians. But they said, you know, a lot of this has to do with what we do. We're comfortable now going at risk, and we will take the risk. So the employees aren't the first people that get cut, and that we don't have to shed those programs. And that was something that came with an evolution, but I think it represents this partnership mentality. It's something partners do when they own a business as opposed to employees when they're trying to maximize their income, and that came from them.
A couple more questions. Recruiting physicians, nurses, pharmacists, psychologists, other professionals to the integrated model, tougher, easier, better, worse?
It's easier, but it's, in some respects, you have to be careful because not everybody is cut out to be part of an integrated group practice. Back to what I talked about, there are some physicians who take this accountability to the point where only they can decide, and they have to decide everything, and they don't make good partners. So you have to be careful in your recruitment process, and so we do a lot of work on pre-recruitment. But yeah, it's been, I think, the way people want to go. And of course, the other model is a young physician, she or he come out with my daughter, for example, $250,000 in debt. She's going to buy into a practice? You know, I don't think so. That just isn't in the cards, and I'm not going to help her. And so,
She know that, but
yeah, I said that on day one of the medical school application process. But you know, they're not looking for that. That's not the lifestyle that they're looking for, and so I think they're looking for support, and I think most of them are looking for just a way to practice good medicine and get good support, and in many cases go home at 5 or 6 o'clock at night and not be bothered by the phone call. And in a big system, can allow that to happen, and we have implemented our call system across the whole system, so you can be in Virginia or Ely or Ashland and still have this huge call system behind you in terms of Nurse Online and so on. So the docs, by and large, have a much better lifestyle as part of a bigger system than they would independently.
you have physicians on the health system board. Have any independent physicians on that board?
No,
Why not?
because they're independent, and that doesn't fit with our direction, and it doesn't fit with our agenda. I think by definition they have a different focus. They don't have the same perspective as we do, and no, we don't have any independent physicians.
Last question, and I'll open it up to our students, and I'm sure they have some good questions for you. You're the CEO of an integrated system who also happens to be a physician. Must CEOs of integrated systems be physicians? And if the answer is yes, do they still have to practice medicine? Do you believe
Sure.
that do they have to be physicians, and if they are physicians, do they also have to practice medicine?
I would say no, they don't have to be a physician. And in our Brainerd facility, we call them presidents of the integrated group, is not a physician. I've talked often at the leadership table and at the board level. I think for many years, CEOs have come in two flavors. They've been in the finance flavor or the operations flavor. I think there's a new flavor now called clinical, and I think that equates to the physician. We're a $1.5 billion organization with 18,000 employees. There's no way that I'm going to leave that, I think, mission and that organization in the hands of a person who may have an MD behind his or her name but is totally incompetent. That just isn't going to happen, and I've made that real clear. I said, as physicians, we have an opportunity to lead if we choose to lead, and I think this is the inconvenient truth in healthcare, is that as physicians we have abdicated that responsibility, and we've kind of sold out for the big bottom line or the big paycheck or the big W-2. And I said, then we sit on the sidelines and complain and bitch about how we're being poorly treated, and we've lost our, I think, the credibility that we once had as a profession. I said it's up to us to change that. So I'm a firm believer in physician leadership. I think it's great if you can find those individuals who have those skills. We do a lot to educate our docs. We have a number of them who've gone off and gotten their business degrees, have a lot of them going through leadership colleges. But I think at the end of the day, the organization has to decide if there is a pool of people, and if it is a physician, is he or she competent to do the job. And then that's a whole nother conversation. Sometimes you have the hood ornament physician CEO, and everyone knows who's driving the bus, which is the administrator, and that's a fair model, and we see that a lot. That's not been the approach that I've taken. And I think the question that you asked about practice is important at the beginning. I practiced I practiced for 18 or 20 years, even when I was in governance and then as a president, and I was probably president of SMDC for about a year, taking weekend call one night a month, which I still dream about, because it got so bad, Dan. I had the lowest quality of anybody in our group because I was so infrequently in the hospital. And finally my partners came up and said, stop this charade. We know what you're trying to do, which is to prove to us that you can do it all. The reality is you're the worst clinician in the hospital, and we hate it when you're on call because you're on the phone all the time, and we got to crawl out of bed and come in and bail you out. Please stop practice. And so our group now is growing beyond that, and it's not in our culture, but we had to kind of work through that. And in Fargo now, our physician, who is an obstetrician, who is our president of the Fargo group, he still does surgery, but he's not doing an active OB practice, and I see him quite quickly walking away from that. So I know Mayo is different, and it may be that others are different, but for us, it's not that important.
Oh, I appreciate that honesty. I'd like to turn to the students. Any questions you'd like to ask Dr. Person while he's here? It's difficult to see you out there, so just shout one out because I can't see you. Go ahead.
Yeah, I have a question about market and integration. You talked a lot about your market as being, Duluth services rural markets.
Right.
In a fully integrated model, what are the advantages, disadvantages for that model in a big metropolitan area versus sort of a more rural serving market? Are there any disadvantages or advantages?
Let me repeat the question because it's a good one. I want to make sure people hear it. The question, if I get it right and help me, is that is the integrated model better in one place or another? Is it better in rural or urban, or does it really matter?
Doesn't matter. Yeah.
I think it's an essential, a must in small town America. You see these little group practices competing with the hospital, and little group practice will have physical therapy, and the hospital will have physical therapy, and then they've got all these medical directorships, medical directorship of dietary services, and it's crazy. So I think in a small town, it's just the only way to go. I think in Duluth and in our experience, I would say it's the way to go. Our competition has an integrated model. It's not the same as what we have. And I think almost all of the Minneapolis-St. Paul is in one way or another integrated. Now they have different models of how the physicians work within the practice. In some respects, there may be more reason to quickly form alliances in a metro area with your physicians because there's so many options close by. And so the last thing you want to have is like in Indianapolis where there's 5 or 6 systems and you put up a new hospital and you have no loyalty from your medical group practice. They can go anywhere they want and whoever offers the highest medical directorship reimbursement, So I think it's in some respects possibly even more important in a metropolitan market than it is in a market like Duluth, where there isn't many places for me to go. When I started, I practiced at St. Luke's and I practiced at St. Mary's. As my practice grew, and we found this with orthopedics and we found this with neurosurgery, and as we became more sophisticated, our docs, especially our surgeons and our proceduralists, felt it was difficult to go down the street because it was a whole new tech team, it was a whole new surgical suite. They weren't as efficient. It took longer to get down there, and so we almost integrated our medical practices just based on the sophistication it requires now to drive a practice. So I don't know if that's answering your question, but I think everyone's going to get there. It may be even more important if you're a hospital administrator or a system head here to find that loyalty. And then you can begin to have those conversations with the Blues or the other commercial payers. It would be real hard to do that, and all of a sudden half your providers write a contract with the competing hospital and they're all of a sudden out of network the next year. It just makes it tough to make investments in group practice and clinical service development when tomorrow they may be gone.
Any other questions?
I have one.
Okay.
My name's Nathan. I work for WellPoint,
Yes.
and I had a question about the question I was posed to you about if the CEO needs to be a physician, and I liked your answer. But my question is, we talked about it earlier in class, and someone had mentioned, well, in the healthcare industry or hospital environment, you're not making and selling widgets, you're dealing with human lives, stuff like that. And it made me think about my dad, who's an airline pilot, and you have these pilots that are responsible every day for flying thousands of people around the world and their safety, yet nobody seems to be concerned if the CEO of a major airline is a
Right.
pilot. Why is there such a stigma that the CEO of a hospital needs to be a physician, and does that come from the outside, from a public perspective, or is that an internal, or both?
Well, let me see if I can rephrase. It goes back to the issue of as systems move to more integration and physicians are really committing their careers to the integrated model, they're by definition giving up the independence. The one argument for the physician CEO is the physician CEO has the experience of seeing patients, being in the trenches, been in the trenches, and has a different perspective, will be respected by other physicians, and consequently is perhaps a better CEO candidate.
It's an excellent question, and I've asked myself frequently, what is the difference? Why, although there is one airline, and I can't remember which one it is, that has a pilot as the CEO. As someone who went as far as soloing and decided that I was going to be really hazardous to my health, and you could ask your father about this, I think being an airline pilot is a much more solo and independent relationship. It's an A to B or an A to B to C, as opposed to being a physician, which is I work with a cardiologist and a neurosurgeon, and my patients are moving through large buildings and structures and facilities, and there's just a lot more complexity than putting 150 people in a tube and going up in the air and then coming back down. They are very similar to us, and yet in some respects they're a much more limited focus in terms of the network of people that they interact with. That's about as good as I can do. I think that you look at other professional groups, lawyers, you look at the professional groups of accountants, and that they often end up having their senior person being a senior lawyer or a senior accountant with an office manager or so on. Maybe it's part of the training. I can't explain more than that why in the profession of medicine it has seemed important for physicians to see a leader being a member of the tribe, so to speak.
But your position is that in an integrated model, you need the best trained, most competent person. They may or they may not be a physician.
Right. And if I can use Park Nicollet as an example, Park Nicollet came into being the same, about 2 years ahead of SMDC. Fairview University emerged the same time as we did. Jim Reinertson ran Park Nicollet, a physician, a rheumatologist for a long time, and then he moved on and Dave Wessner took over, and now they have a new physician, Dave Abelson, who is running Park Nicollet. I see that as probably the pattern that you'll be seeing in in healthcare systems, where there may be a time where you really need a strong administrative lead, and it may be right for you at that particular point in time. We're in this integration part of our life cycle, and that really requires physician leadership. We are integrating and merging with physician group practices who are way, way behind where we need to be, and I think they find that the physician leadership model is attractive. It may be, as I said, when I retire, that we go for a number of years with a non-physician, but at the end of the day, you need the most qualified person to run the system, and if it can be a physician, great, but doesn't necessarily have to be.
Well, I want to thank you on behalf of the students, on behalf of the executive MHA program. It was very kind of you to spend your time with us. This is an important part of this week, and the whole issue was really the structure of the integrated model and its potential for innovation. And I want to thank you for taking your time. And
Thanks,
it was a
Dan.
pleasure having you.
Thank you.
And thank you, folks, for spending such a long day with us today. Tomorrow won't be as long, but I hope it was a good day for you, and thanks very much. We'll see you tomorrow. Okay? Do you want the folks, do you need the folks to stay for that? Okay. You want us to sit and pretend like we're talking to each other and nod and...
Yeah, thanks, Dan. Good,
Any
good,
more?